Good morning, everybody, and welcome back to the Neurocon International Conference 2022. To break the ice today, I am more than thrilled to introduce you to Professor Omer van den Bergh, our first speaker of today. He's a worldwide expert in health psychology and coming from the little medieval town Leuven in Belgium. The fields of study he's known best for is internal medicine, cognition, and anxiety. And up to date, he has reached over 200 publications, their influence being of value globally when we are talking about health. Professor van den Bergh scientific interests lie mostly in developmental, cognitive, and social psychology, and also classical conditioning and cognition. For example, his research in classical conditioning tackles topics related to areas such as reinforcement and flavor, where we have the famous study of the flavor, and color flavor conditioning in humans. Regarding his studies of developmental psychology, he conducted research into psychosocial well-being and how to translate clinical and health psychology into professional tools and intervention methods. This had led us to the topic which he'll present today, namely symptoms and the body and inquiry to their relationship. So without further introduction, I am honored to now welcome Omer van den Bergh. Good morning, Professor.
Good morning, Luana. Thank you for your introduction. I can start with my presentation now. Okay. I would like to tell you a story about the relationship between symptoms as we experience them and bodily processes. And typically, when you go to the doctor, you have a self-reported symptom, and what the doctor does then is he or she tries to map the symptom reports onto a physiological dysfunction, and this is actually a diagnostic step. And then the doctor tries to remedy the physiological dysfunction, which is a therapeutic step, and the assumption is that the self-report symptom would go away. When this process doesn't fit very well, then we have a problem for both the doctor and the patient. So in that case, doctors typically talk about medically unexplained symptoms, or very often they are bumping into persistent somatic symptoms. There is actually even the difficulty to find the proper name is important, because it shows how poor our verbal array is to describe situations where the disease model doesn't fit. Now, how often does that occur? Well, in somatic medicine, in primary care, for example, about 1/3 of the somatic symptoms remain medically unexplained or are categorized in some way as persistent somatic symptoms. That means these are symptoms where the disease model doesn't seem to fit. When you look at different medical specialties like gastroenterology, neurology, cardiology, pulmonary clinics, and so on, you see that about 1/3 to half of all the consultations end up with some kind of diagnosis that captures the idea that the medical the disease model doesn't work, and then you hear words like idiopathic and somatoform and non-cardiac chest pain and those wordings. But overall, it shows that 1/3 to half of the consultations in somatic medicine end up with a situation where the disease model doesn't seem to fit very well. And when you look at those patients, they are typically reporting elevated anxiety and depression scores. And there are also in somatic medicine a number of labels like fibromyalgia, chronic fatigue, multiple chemical sensitivity, irritable bowel disease, but also whiplash and a number of other, and probably long COVID is also part of that group, that are categorized as functional somatic syndromes, and they are highly prevalent in the general population. There is a considerable overlap among syndromes, and they all share some non-symptom characteristics, like a predominance of women and substantial correlations with indicators of negative affect and elevated psychiatric comorbidity. In psychiatry, we have different labels. In DSM-5, for example, the label somatic symptom disorder is used, or in ICD-11, bodily distress disorder is used to indicate actually what previously was called somatization disorder. But an interesting finding is also when we look at healthy students, for example. And these are data from psychology students at our university. And when they arrive to start their study, we screen them using a lot of questionnaires, and many of you are probably familiar with this practice. So we have a group here of about 1,500 students. They all report of themselves that they have no disease, that they don't take medication except contraceptives. And when we control for content overlap between items of the different questionnaires, we see that there is a correlation between negative affectivity, which we measured here with the PANAS on the one hand, and on the other hand, total symptom score. So this is without all anxiety-related or emotional-related words. And so we see a correlation of about 0.42 in healthy students. But you can do this exercise with all kinds of population and all kinds of questionnaires, and you will typically find the correlation, let's say, between 0.40 and 0.55, which basically means that if I know how you feel emotionally, I can pretty much predict how many symptom reports, how many symptoms you will be reporting. And when we also look into well-explained diseases, then we also can question how much of the symptoms are actually related to the disease pathology. And this is, for example, data from COPD patients. This is about 5,000 patients with chronic obstructive pulmonary disease. And you see here 5 grades of dyspnea or breathlessness. And within these are 5 different degrees of breathlessness. This is the lowest degree, and this is the more severe degree of dyspnea. And this is the distribution of FEV1, that is forced expiratory volume in 1 second. All the dots here are patients, and you see an extremely wide distribution of FEV1 within this grade 1 dyspnea or breathlessness. And when you calculate the correlation between FEV1 on the one hand and dyspnea reports on the other hand, you find a correlation of 0.28. There is another study who finds 0.36, but when you look across different studies, you will find a correlation of around 0.30, 0.33, something like that on average, which means that one of the major indicators of pulmonary health is actually predicting only or explaining only about, let's say, 10% of the variance in breathlessness, which is not a lot. And compare that with negative affectivity, which correlates 0.40 to 0.55. And then you understand that even in respiratory diseases, because we for example, we reviewed across respiratory diseases especially asthma here, how symptom reports related to FEV1. And then you see that in about 50% of the patients, there is a poor correlation between FEV1 and asthma reports. And trait negative affect is an important moderator of asthma symptoms, as we found here in this review. You can also look at cardiac diseases. And for example, when you look at the degree of coincidence between self-reported complaints and objective Holter data, this correlation is virtually zero. And about 20 to 45% of the patients with fibrillation reported symptoms. They report symptoms in the absence of actual tachyarrhythmias. 40% of the cardiac function measures for self-reported symptoms are negative. That means are not related to any physiological dysfunction. And negative emotional factors predict symptom reports better than any objective measure of cardiac disease. So here in cardiac disease, we find a bit the same situation as in respiratory diseases, and I could go on with gastrointestinal diseases and tell you the same story. But let me summarize. So there seems to be a pervasive relationship between symptom reports on the one hand here and negative affectivity on the other hand. And we find that in the normal population, we find that in primary care, where you have frequent consulters, and these tend to be more anxious and depressive. And you have that in functional syndrome patients, and they tend to report elevated psychiatric comorbidity. And the correlation seems to be stronger from negative affect in the direction of symptoms than reversed. What is trait negative affectivity? Well, other labels are familiar to you probably. Neuroticism, dispositional negativity, threat sensitivity. It refers to a broad, stable disposition to appraise situations as more threatening and to experience negative mood states and emotions. And it seems to correspond to a number of cognitive features like attentional bias, interpretational bias, repetitive negative thinking. It correlates with enhanced threat responding, compromised fear learning, a tendency to experience negative emotions. It refers to psychophysiological hyperarousal, to behavioral tendencies towards avoidance, and a number of characteristics at the neurobiological and the genetic level. And so it seems to refer to an embodied way of being in the world. And we know that it is a general vulnerability factor, but also an underlying factor of most emotional psychopathology. To summarize this part, medicine tends to neglect that all symptoms come about in the brain, and often there is little or no link between objective physiological dysfunction. And the question I would like to address further for the rest of my talk is, what has negative affect to do with it? So in our next block here, I would like to show you a bit of our approach of this problem. And we wanted to develop a paradigm to create medically unexplained symptom reports in the lab, which is basically a nocebo paradigm. How did we do that? Well, when you enrich breathing trials with CO2 enriched air, if you add some CO2 to breathing air, like 5 to 7%, at maximum 10% of CO2 to the breathing air, you create a number of physical symptoms here, like fast breathing, smothering sensations, chest tightness. Actually, it feels a bit like you have been running up the stairs very quickly, or if you have been running 100 meters very fast. But the major difference is that you can feel that while sitting in your couch. And interestingly, CO2 is odor and tasteless when it is inspired in low concentrations. And so we used a number of samples here, non-consulting participants, and we divided them into high and low habitual symptom reporting. And we also looked at clinical patients, mostly patients with functional somatic syndromes, and we compared them with matched controls. And so one of our preferred paradigms was an associative learning paradigm. So you can imagine, for example, that you are inspiring a number of breathing trials, and we added harmless odors to the breathing. And these odors could be unpleasant or pleasant, while you were either having CO2 inhalation or room air trials. So imagine that you are inspiring a number of breathing trials that you are going through a number of breathing trials for 2 minutes each. One of these breathing trials could contain CO2 and would be associated with one harmless odor, and then you would have room air trials associated with another odor. And then the question becomes, what about the symptoms after presenting the odors only? That means we leave out the CO2 from the breathing air. And this is a typical finding here. When we used ammonia as CS+, because you will recognize here a conditioning paradigm, CS+ means previously mixed with CO2, and CS- means not previously mixed with CO2. Bottom line, and it's maybe a bit complicated to explain this graph completely, but the bottom line is that when symptoms were induced by CO2 associated with a foul-smelling odor, a bad-smelling odor, you could present the odor only, and people would start reporting symptoms as if they are still getting the CO2. Interestingly, this only happens when the odor cue was unpleasant. If you compare this with the Naioli odor cue, which is sort of a fresh-smelling odor, then you don't see these learning of symptoms occurring, which is an interesting finding in itself. Another interesting finding is when we split up the group of participants into high and low NA people, you only see the symptoms learned by the high NA people. And when we compare it with psychosomatic patients in the hospital here, that means patients with dyspnea reports without being able to link them to physiological dysfunction, they are actually the better learners of all. So to summarize a number of findings with the symptom learning paradigm, so symptoms can be easily learned, but this is moderated by high trait negative affectivity, negative valence of the cues, or belief about harmfulness. Because if we say bad things about positive odors, then we also induce symptom learning in that condition. We have replicated that and expanded that, and I'm not going to explain all those details. So we have a quite robust body of evidence that symptoms can easily be learned. So another summary for the moment. Symptoms can easily be uncoupled from physiological dysfunction. Then the symptoms rely on automatic activation of a mental model of the previous symptom experiences, not on hypervigilant inspection and interpretation of bodily responses. But the question is, why does it happen only in some people, the one prone to negative affectivity, and why only with some cues, the ones having a negative affective connotation? So we wanted to understand this, and we started to play hide and seek with symptoms and use affect as a critical cue. So a symptom A, for example, can be largely determined by direct physiological input. But after a while, it can actually be completely determined by memory activation and actually become the same symptom can actually change the cause of the symptom across a number of experiences, as we have shown. What is the role of affect in this? So we try to understand this by playing around with CO2 inhalation, and imagine that we have people breathing through a system here inspiring CO2, and we start to play around with the valve of the CO2 cylinder to induce changes in minute ventilations and changes in end-tidal CO2 in the body, which we measured here in the system. And then you can imagine that you go through a sort of a CO2 roller coaster by playing around with the valve, and then we ask people to rate either faster or deeper breathing or breathlessness. And in the first one of the studies, we actually had people going through the same CO2 roller coaster, and we divided them into high and low negative affect persons, but we added a negative frame in one context, and we said participants, breathing this air may make you feel tense, like when being anxious or expecting something terrible to occur. And in another condition, we added a positive odor, and we said breathing this air may make you feel tense, like when being in love or looking out for something really nice to happen. And so this is happening with the within subject. I have to explain that. We look at the within subject correlation between the physiological changes on the one hand and the symptom reports on the other hand, because we have them reporting the symptoms like every 10, 15 seconds. When we look at the body symptom correspondence, and when we look at the positive frame, information frame with the positive odors, there is no difference between the high and low NA people. But when we put them in the negative frame, you see that the high NA people actually show a serious drop in body symptom correspondence. And when we look at the symptom level, they start to report most symptoms in a condition where the symptoms are actually almost unrelated to the physiological dysfunction that we induced. We also did another experiment in which we had people rate faster or deeper breathing, which is a neutral rating, and we compared that with breathlessness rating, which is a symptom-related rating. And we compared high and low medically unexplained symptom reporters. And when we used the neutral phrasing, they actually showed no difference. But when we used the symptom reporting, the high medically unexplained symptom reporters were actually showing a serious drop in body symptom correspondence. We also replicated that in clinical patients with medically unexplained symptom reports, their symptom reports tend to correlate a lot less with the physiological dysfunctions. To summarize this part, well, the body symptom correspondence drops in people with high habitual symptom reporting and in patients with functional somatic syndromes when confronted with unpleasant cues. And actually, they started to report symptoms without using the bodily input anymore. So this is prompting the question, so the distinct physiological input may not be necessary at all. And so we tried to further dismantle the process and induce negative affect as a sole cue for symptoms. So we started to do experiments with inducing state negative affect, and we showed them pictures of positive objects, neutral objects, negative threat related or symptom related objects. And then we simply gave them a questionnaire in which we inquired about different symptoms like tightness of the chest, pounding of the heart, stomach, abdominal cramps, and so on. At the same time, we measured also bodily responses like heart rate, skin conductance, and EMG, and those things. An interesting finding is that when we looked at the valence by arousal of the pictures, that means high negative valence and high arousal, which would be in this condition, and this would be neutral condition, we could observe in high medically unexplained symptom reporters a very nice dose-response relationship between, on the one hand, negative affect that we induced, and on the other hand, symptom reporters. So we find a dose-response relationship between the NA level with symptoms, which occurs only in high medically unexplained symptom reporters, and we found no relationship with physiological arousal indicators. Sorry. We also applied this paradigm to chronic fatigue and fibromyalgia patients, about 90 of them, and we obviously we showed here the symptom ratings. These are the healthy controls, no effect at all between viewing negative affective pictures. In the patient group, obviously, we had a main effect of symptoms because a symptom reporting, because these were patients, but we saw a clear modulation by negative affect pictures. So these patients reported more core symptoms, fatigue or pain during negative affective picture viewing. And this was again unrelated to physiological indicators of arousal. An interesting finding was that this was mediated by the difficulty to identify feelings, which is a subscale from the Toronto alexithymia scale. So it seems that people who have difficulties to identify feelings, they seem to merge or blur symptom reports with negative affective states. So this brings us to a very basic question. What is actually a symptom? And one of the major views on that is the dual process view. And when we indicate a symptom, for example, on a rating scale, we make an intuitive integration of, on the one hand, an effective motivational value of what we feel, and on the other hand, a number of sensory perceptual details like intensity, duration, location, and so on. Now, we just showed that in high habitual symptom reporters and in functional somatics symptom patients, they show stronger affective responding to all kinds of physiological inductions, and they show a blurring of affect and nociception. So the question is there also something that we can observe regarding sensory perceptual impact? Sorry, I have to take a sip. We also did a number of studies, and to summarize this, we can basically show that these patients, these participants, have also a reduced perceptual processing of somatic stimulation. We find that as a result of we find that, for example, as absent of a peak and memory bias, which I'm not going to explain now, but also the retrospective memory of a distressing event is much less detailed compared to other participants, control participants. To summarize, I'm sorry, I have just had a cold. But when we compared when we induce aversive somatic events in high habitual symptom reporters and functional somatic symptom patients, we see less detailed sensory perceptual processing and a blurring of negative affect and nociception. And this is explaining why learned symptoms occur to negatively valent cues only, why there is a low body symptom correspondence in negatively valent condition. And when we induce negative affect, that it triggers somatic symptom reports. So we wanted to understand and see what happens in the brain when we create negative affect-induced symptoms. So we brought IBS patients and fibromyalgia patients to the scanner. We present them with the pictorial cues here. We left out the threat-related and the body-related difference because these were not making a difference. And we assessed the symptoms again, as you can see here. And this is the result for affect. You see that healthy controls, they also show a negative affect induction. And also the patients, but they showed stronger negative affect induction by looking at the pictures. And when we looked at the symptom reports, we see that the patients only show exaggerated symptom reporting in response to the negative pictures only. And when we looked at the brain, the whole brain findings, we saw that there were differences in somatosensory and primary motor cortex activations, and especially also the posterior insula and the anterior mid-cingulate cortex. And these are typically involved in nociception. And then we also looked at patterns of interest. And patterns of interest are comparable to regions of interest, but the difference is that these are machine learning derived functional organization patterns or distributed response patterns during pain induction. That was one pattern of interest. We looked at our results. Another one was picture-induced negative emotion, which is the pain pattern, or the PINES pattern, I would say. This is the nociception pattern. And stimulus intensity independent pain signature, which is a SIPS pattern. This is referring to cognitive affective modulation of nociception. For example, if you give people control on pain, they typically report less pain for the same nociceptive stimulation. And so we looked at the different, you can compare this as glasses, as frames to look at brain activation patterns through these looking glasses. And what we can find here is that the nociception pattern, the nociception or the neurological pain signature, is indeed different for the healthy controls compared to the functional somatic sensation patients. And they show stronger activation response patterns. We don't see a difference in the PINES pattern, and we also don't see a difference for the SIPS pattern, which means, and when we do a mediation analysis, what is clear is that the symptom reports, the difference between the patients and the controls, is mediated by activation of the nociception pattern here. To summarize this, actually in this group, the brain treats negative emotional information as aversive somatic information. It's actually blurring those two states. And it seems to be due to an automatic co-activation of a typical pattern for nociceptive responding. that is automatically triggered by negative affect. And we occasionally see a moderation or a mediation by having difficulties to identify feelings or childhood trauma, which I didn't show you actually. But there's a questionnaire here. Our studies are typically not powered enough to look very carefully at moderation and mediation patterns. But okay, let's go on to the next block. What does it actually means about symptom perception? Are we actually perceiving symptoms, or are we actually constructing symptoms? Well, to start immediately, according to me, symptom perception is not being able to detect a minus signal in a noisy environment and then pay hypervigilant attention to it and give a cognitive interpretation to it. Conversely, symptom perception is classifying a pattern of sensations into meaningful categories with behavioral relevance. You can compare it to, for example, meaning perception in of these objects here. These are four completely different objects when you look at their perceptual configurations. But you will immediately see four chairs here. And this is because of a complex inferential process that dramatically compelling percept of seeing a chair. Actually, you cannot not see a chair anymore here. And this is all due to the fact that we have a categorical prior in our brain of what it means to be, of what a chair is. Without any categorical prior in our brain, we could not immediately see these four objects as all examples of a chair. The same is actually probably going on in symptom perception. And so the question is, how can we perceive symptoms that are actually not there? And that's a very basic question, because we also know this from placebo and nocebo research. And obviously, experts of visual perception are very familiar with the fact that we can see things that are not there, and sometimes we don't see things that are there. And I'm not going to explain those visual illusions, but you're probably very familiar with that. And visual illusions are the royal road to understand normal visual perception. They are not just only funny things. They actually are illustrating the basic mechanisms of what visual perception is. And I would like to submit to you that symptom perception of symptoms where there is no relation with physiological dysfunction is also actually the royal road to understand interoception and symptom perception as a constructive process. And recently, there is a lot of interest for a new way of looking at the functionality of the brain. It's known under the label predictive coding, predictive processing. And just to explain you a couple of basic elements of that, it has to be clear that the brain has no direct access to the distal world. The brain only has its own neural activity to make sense of. And the major task of the brain is pattern detection in its own neural activity to make a causal model of the external and the internal world. And it does so by informed guessing. That means it uses predictions based on the information the system already has. And this is why it is called Bayesian. sometimes. And the criterion is actually adaptiveness or usefulness, not accuracy. So an accurate model is mostly adaptive, but bias can be more adaptive than accuracy. And how does it do so? Well, it's a bit complicated, but you can imagine that on one hand, there is input from the senses or from the body, which is relayed to the brain, and at different hierarchical levels, predictions are sent down to meet those signals from the input. And at every hierarchical level, prediction errors are created that are propagated through the system to eventually come up with a posterior model that is a model of reality or a model of our internal state with the lowest overall prediction error. And making a causal posterior model so uses priors or predictions on the one hand and prediction errors on the other hand. And you can conceive of them as distributions of active neural populations with a reliability, each of them, and the relative reliability determines the contribution to the percept. And this is sort of shown here. Here you have a high precision of the sensory signal, which is represented here. And this is the prediction. And you will see that the eventual percept will be closer to the sensory signal. But in this case, you have a low precision of the sensory signal, and then the eventual percept would shift towards the predictions. And so the conscious experience of a symptom unrelated to physiological dysfunction occurs when the posterior model of the bodily state is completely determined by strong nociceptive priors. And these symptoms are experienced as equally true or real because it uses the same machinery as objectifiable symptoms. And we have seen that nociceptive priors are actually automatically co-activated with negative affect. And when combined with low precise prediction errors, that is, low sensory perceptual detail of interoceptive processing, or low specific systemic responses related to stress, for example, like autonomic immune responses. In those cases, these nociceptive priors will completely determine the eventual symptom percept. So this is actually my story, but I would like to briefly end with some treatment considerations, because medically unexplained symptoms are actually often not diagnosed in primary care. There are long delays between symptom onset and treatment. This is what we know. And almost half of the patients don't receive any treatment at all. And when we do treat them, then we see that somatoform disorder show an overall low, moderate to low effect size, which is much lower than our treatment effects for social anxiety, panic disorder, general anxiety disorder, major depression, and so on. We see that overall the effect size is way too low. So what we are doing is way too little and way too late. And I would like to end also, are we hitting the right targets? So we focus now way too much, in my view, on post-perceptual processes like attentional hypervigilance, misinterpretation bias, checking and avoidance behaviors. And we are using therapies with known effectiveness, but not relying on mechanistic causal understanding. We use mindfulness-based therapies, acceptance-based therapies, body-related based therapies, because we know that these therapies have overall an observable effect, but we apply them here without actually focusing on the mechanistic processes. So I would like to bring back perception into symptom perception. And what we should do actually is altering perceptual priors. And we should link up with perceptual research on body illusions, for example, like the rubber hand illusion, whole body illusion, phantom limb pain, and placebo and nocebo research. And as you have seen, these are actually the basic two problems. We have a blurring of negative affect and nociception and less detailed sensory perceptual processing. So my suggestion is that we should focus really on interoceptive exposure to diminish the effect of nociceptive priors. But on the other hand, we should also focus very much on interoceptive differentiation training, where we should people learn to differentiate emotions and emotions among each other and somatic states among each other. And there are some preliminary findings that actually show the effects of these kind of approaches. To summarize with some take-home messages, all symptoms come about in the brain, and the interoceptive brain constructs symptoms through an inferential automatic process, producing a compelling sense of trueness, balancing predictions and somatic input. And physiological dysfunction is thus only one type of input, and predictions by the brain is another. And a close link in acute conditions typically shows up if you have a strong somatic input with a very narrow symptom profile. Then in those conditions, the symptom reports will almost perfectly correlate with the physiological dysfunction. But the links becomes much more loose in multi-symptomatic chronic conditions, and that is because contextual cues are more and more taking over in determining symptom reports. And under certain conditions, symptoms are completely uncoupled from physiological dysfunction. And in that case, medically unexplained symptoms are actually extreme exemplars of mechanisms that are everywhere present in medicine. And treatment should target directly mechanistic processes. And I will not elaborate on physiological dysfunction in this context. That's another story for maybe another time. So thank you for your attention. This is our health psychology group in Leuven when I was still chairing it. And this are some views from Leuven as a small university town. Thank you very much for your attention.